Okay, my talk is about MRI, so advanced neuroimaging at 3T with a 32-channel head coil. So, by the way, this is where I work. This is Kyoto University Hospital. From 1.5 to 3T, what's the advantage of it? Well, as you well know, signal increases quadratic to B0, which is a static magnetic field strength. And however, noise also increases linearly. So signal to noise ratio increases linearly. It's already known. And as for the fMRI, when we use checkerboard stimulation with the different frequency stimuli, then we have double times or 2 times steeper signal increase if you use 3T. So usually, in general, rule of thumb, 2 times for the signal or for the contrast, or I mean board contrast. So that's the advantage of the 3T. And this is a system which we use, we use this with 32-channel head coil. And as for the head coil, prototyping was conducted by QED Incorporated, which was funded by NYBIB, which is a kind of branch of NIH. And during that report, it is said that for the next generation 3T or brand new 3T, not conventional channel is enough. At least you have to go to more than 16 channel. So this kind of head coil with multi-array is now required. So if you go from 14 to 32 channels, you have this kind of SNR profile. If you see, this is at the very edge, much higher, probably 1.5 times higher SNR can be obtained. And even at the center, the SNR is a bit higher than 14-channel coil. And this kind of signal advantage can be used to increase image quality or increase time resolution, I mean speed. So I will touch upon these 2 issues. So first one is high quality. So even using default 14-channel head coil, at 3T, you can have very high-resolution images. These are 512 image, so the in-plane resolution is less than 0.5, and through-plane resolution is 3 millimeter. Even using this high resolution, on T2 weighted image, you can see very high delineation, although the noise, I mean white noise, is a bit obvious. And also flare, the same is true. However, if you go to 3T, you can have much better images. So with the same resolution, you can have this kind of less noisy and much more well-demarcated images can be obtained for T2 weighted image or flare image, and this is a T1 weighted image. Actually, this was acquired by just one slice, so the contrast is quite maintained even going at 3T. In some cases, you have to use inversion recovery for preparation of the contrast. So 3T with 32-channel head coil in the 2D mode, you can have this kind of very, very fine resolution. Although if you go this higher, then the white noise is a bit obvious. Okay, and let me present a case. This is a case of glioblastoma multiforme using 14-channel head coil. This is the flare image. You can see the tumor extension with some kind of non-specific white matter abnormal signal, and also edema is included in this case. It can be clearly visualized. And if you apply a gadolinium contrast material, you can see this kind of high contrast enhancement. And also, you can also see the MR spectroscopy, the elevated choline level at the enhanced area. if you go to 32 channel, MR spectroscopy becomes much better. If you choose one box cell within a glioblastoma multiforme, different case, you can have this kind of clear view of the elevated colline. And the baseline fluctuation is quite small. And of course, even at 32 channel coil, or much better, you can have the better view of 2D CSI images. And go back to the GBM case again. And this is the enhanced area. As for these areas, if you apply the dynamic perfusion weighted image, then you can have the increased cerebral blood volume image like this. And yeah, that's what you are usually doing, but you can go further more. So using 3D ASL, you can also have the similar information without using contrast material within, well, around 3 minutes, which is quite fast, don't you think so? This is almost covering almost the entire brain. So quite easy for us for clinical purpose. Okay, ASL can also be used for other usage. That is ASL MRA. When you use shorter inversion time, in this case, 800 milliseconds, then you can visualize MR angiography quite well. But if you take a little bit longer inversion time by 0.4 seconds, then you can have detailed, minute information of the vasculature. It's quite impressive. And this kind of higher information with higher SNR can be obtained by using 32-channel head coil. And also, 32-channel head coil allows us to get 3D T1 or T2 weighted images within a reasonable time. This is a contrast-enhanced T1 weighted image of the glioblastoma multiforme. Because these images are acquired in isotropic, that can be reconstructed in multiplane like this. And also, as a T2 weighted image, you can choose MVOX acquisition, which is a kind of fast spin echo imaging. In this case, the resolution is 1 cubic millimeter, and the acquisition time is less than 4 minutes. So what is MVOX? MVOX is a Toshiba implementation of the variable flip angle. So the signal itself is rapidly stabilized, and echoes are taken, so many echoes are taken that MVOX can be acquired in a very short period of time. Okay, as for the MR angiography, of course, time of flight might be the standard. And using 32-channel head coil, this kind of very, very high resolution image can be obtained. This is 0.3, 0.3 by 0.6. And very, very detailed anatomy of the arteries visualized. So something like this. Okay, this is a time flight, but this is a white blood angiography. But there's also a black blood angiography, which is often used for the carotid imaging, but at the same time, as you well know it, that's SWI, which visualizes arteries and also veins. But in Toshiba, there's another option, which is called FSBB. Please look at it. What is your impression on it? So I'd like to ask you, how many people know about FSBB? Those who know FSBB, please raise your hand. Very limited? Have you never heard that? Okay, FSBB stands for flow-sensitive black blood imaging, which is quite comparable to SWI, actually. And the acquisition is conducted using 3D field echo, or 3D gradient echo. So if, in the case of the acquisition, if the flow rephasing or gradient moment nulling is applied, then the images become flow insensitive. So FIBB, flow insensitive black blood imaging can be acquired. The reconstructed image is SWI, which is just magnitude, not phase modified. But when you apply flow dephasing by using motion probing gradient, then that will become FSBB, flow-sensitive black blood imaging. In that case, after the RF excitation, then very weak motion probing gradient is applied. Usually, at 3T, less than 1, B value is less than 1. So usually, for the stroke imaging, you use 1,000. But in this case, just 1, or less than 1 is OK. And after that, refocused again, applied and refocused again, and images data are acquired. So this can be used for the visualization of the small arteries, actually. Sorry, I forgot to tell you about it. In the case of the flow-insensitive black blood imaging, especially if you multiply phase, then that will be much more sensitive for deoxyhemoglobin, which means much more sensitive to veins. However, in the case of the FSBB, it dephases fastly moving spins, which means that much more sensitive to arteries. So this can be used for visualization of the small arteries of the brain. So actually, small artery matters a lot, which has been reported as small vessels, big problems in New England Journal of Medicine, 2006. Especially for the basal ganglia or deep perforators, that will cause lacunar infarction, and sometimes hemiparesis will ensue. And in other cases, at the surface of the brain, especially gray-white matter interface, there will be a cerebral amyloid angiography, which causes hemorrhage inside of the brain. So let me focus on these deep perforators. So when we use brain sample and apply the contrast agent within the arteries, we can see at the basal ganglia area this kind of very, very small arteries. These are called lenticulostriate arteries. This occlusion of these arteries causes lacunar infarction, and it's very important to see that. Have you ever tried to visualize it? Maybe not many people have tried that. So we have to have this kind of very magnified information in order to see these small arteries, and it's not easy. However, that can be visualized even using CTs. This is the result of using CT of 64-channel detector. So when a subject is normotensive, you can visualize this kind of lenticulostriate arteries. Actually, this is a 60-year-old male subject. So what become if the patient have hypertension? This is a result. Same year, 60-year-old subject, then you see this kind of very tortuous and also less visualized lenticulostriate arteries are presented here. So there's a large difference between normotensive and the hypotensive patient, and that data is actually hidden in the contrast-enhanced CT images. But you cannot apply it to many people because you have to use contrast material, and also you have to use use radiation exposure, and that is not good for general people. So we have to implement it in implemented on MRI. In order to visualize lenticulostriate arteries, time of flight has been selected for at 70. For 70, because of the T1 elongation, and these lenticulostriate arteries are well visualized. But I know you cannot choose 70 because 70 is less than 100 all over the world. So only selected people can use it. This is a report from Korea, Professor Cho. And what about 1.5, which is most prevailing around the world? We tried it. As for the time of flight, well, the visualization is so scarce and not easy. However, if you choose FSBB well, much better visualization of lenticular straight arteries. Where we compare them more quantitatively, as for the number of visualized LAC branches, time of flight numbers are very small, around 5 or something, and FSBB, much more. And as for the length, time of flight is shorter, usually less than 20 millimeter. However, in the FSBB, in some cases, more than 40 millimeter. And visualization score is lower in the case of time of flight. However, visualization is much better in FSBB, much higher scores. Okay, should we go black or white? That's the issue, but even if you use white, you can be a bit better. So this is a report. Here you can see at 1.5 lenticular straight arteries. This kind of image was obtained by using background suppression, which in Toshiba it's called source STC pulses, and also water excitation is used. Then background is rather suppressed, and this kind of lenticular straight arteries can be observed using time of flight. However, that have to be improved. Okay, back on FSBB. So in the case of lacunar infarction and hypertension, when there's a lacunar infarction plus and nothing at 1.5 T, as you see, the FSBB visualizes lenticular straight arteries a bit similar. However, if you see the number, or if you count the number, if there's a lacunar infarction, the numbers are smaller than those who do not have lacunar infarction. So number is decreased in the case of lacunar infarction. And in the case of the hypertension, when hypertension exists, then visualization itself is a little bit decreased. However, you can see many branches actually, although it's not easy to count. But when there's no hypertension, of course, better visualization can be obtained. So what is the difference in the hypertensive or normotensive observed in this FSBB? In that case, length is much shorter in the case of the hypertension. So in the lacunar case, the number is reduced, and in the case of the hypertension, the length is reduced. That kind of significant difference could be observed at 1.5 T. Well, what about FSBB at 3T with 32-channel head coil? This is a case of moya-moya disease. So you see, no middle cerebral arteries are visualized. So what become if you observe it with FSBB? You see, this kind of very well dilated and many branches are visualized. Some are quite similar to the size of the M2, and which is very large. And in some cases, this kind of hemorrhage, microhemorrhage, is observed, which will give us much more information, which is not visualized until now. And I hope I could do more work on it. Okay, Toshiba actually provides another choice. That is HOP, hybrid of opposite contrast MR angiography. For the, this sequence consists of two echoes. The first echo gets the time of flight white blood signal. And in the second echo, they get the FSBB, fluorosensitive black blood one. And if you subtract second echo from the first, you have the background suppression as well as better visualization of the small arteries. This is quite good, don't you think so? This is the HOP MR angiography. And this is the actual case. When there's a coronary radiator infarction, if you use just time of flight MR angiography, well, non-visualization of the right ICA and MCA. However, if you choose to use HOP, then you can better visualize some more circumferential or collateral arteries, and more detailed distal arteries can be visualized using it. Okay, let me talk about high-speed imaging. Time is brain, and somebody did quantification. And in the stroke 2006, estimated pace of loss in typical large vessels acute ischemic stroke, then per minute, around 2 million neurons are lost, and 14 billion synapses are lost. And the brain is accelerated aging by 3.1 week. That kind of fast aging can happen. So time is brain, really. So we have to cope with it. In order to do that, we have the parallel imaging method. So long as there's a 32-channel head coil, they have a very small one and very limited sensitivity range. So that can be characteristics can be used for higher parallel imaging factors. Okay, 3T and 32-channel coil for parallel imaging. Without parallel imaging, for this kind of coverage of the MR angiography, it takes around 10 minutes. However, if you go 2 by 1, I mean, in the phase encoding direction, just acceleration by factor of 2, then the imaging factor becomes less than 5 minutes. If you go 3 by 1, then about 3.5 minutes, and 4, then you can go as short as 2.5 minutes. However, at the center, you can easily observe that there's an artifact. So what should we do? We go 2 by 2. Then almost at the same time, we can get rid of that kind of artifact. And visualization of the small arteries are almost the same without applying parallel imaging. If you select the very limited area and apply 2 by 2 parallel imaging factor, then in 48 seconds, you can have this kind of coverage of the MR angiography. Okay. Okay. And as for the diffusion, parallel factor 1, 2, 3, 4, maybe even at the parallel factor 3, the images are quite similar to the parallel factor 1, and quite good contrast to noise ratio, and also the distortion is less in the case of the parallel factor of 3. So within 1 minute, you can have a whole brain diffusion weighted image. And as for the T2 weighted image, we use a very faster one, and I mean the echo factor is very large, and less than 2 minutes, we can cover the whole brain. And if you go 2 by 1, then less than 1 minute, and 3 by 1, around 30 seconds, but a bit noisy. Well, 4 by 1 is too fast, probably. So if you go 3 by 1, then, well, maybe usable for diagnosis, but maybe you had better use 2 by 1. But the acquisition time is less than 1 minute. Okay, if you apply this to the brain infarction protocol, then T2 weighted imaging, of course, less than 1 minute, and MR angiography less than 1 minute, and diffusion also less than 1 minute. And if you add perfusion image, I mean ASL, you get it at around 3 minutes. So in total, around 5 minutes. So it's quite nice, don't you think so? That's the power of the 3T and 32-channel head coil. Okay, there's other features which is implemented in the 3T. This kind of user interface is always important. Actually, at the 3T, user interface is brand new and much more beautiful interfaces presented, and you can use many processing on console. For example, DSC perfusion analysis. If you present this kind of EPI image and take the region of interest, and the signal plot is presented, and also you can set up the parameters on it, and can have the CVV or a CBF with singular value decomposition, and also mean and transit time. Another option is, another function is the analysis of the functional MRI data. Of course, that kind of activated blobs are presented, and also time course signal is presented. And also, for the diffusion tensor imaging, You can have the isotopic diffusion or ADC or FA or a color map or lambda 1, 2, 3 or trace. That kind of information is instantaneously presented. And also you can go more. If you choose, you can do the tractography. This program is based on the DTI Studio, which has created by Johns Hopkins University. So the algorithm is basically the same. Okay, so 32-channel MRI, 3T MRI and 32-channel head coil. Advantage is, some people in here maybe understand this. This is the large, so advantage is very large, I think. Thank you very much.